I thought I'll share one experience from Qatar, just to make a point about the importance of registries. And then I'll talk about at least two areas in Pakistan where we have potential for clinical trials and how to go about that. So first of all, clinical trials. And I finished my training in 1989. So during our first several years, we used to work with neuroprotectants and spend a lot of time, wasted a lot of time, improving from all comers to those with cortical strokes. But the first big event that improved our patient care comes in the early 1990s. 1995 was when the trial on thrombolysis was completed, and it was approved as a treatment for acute stroke in 1996. And unfortunately, 25 years later, we still have challenges all over the world. Some of them are relating to the fact that patients don't come to the hospital early enough, and others are related to cost. Over the next decade, we continue to improve on imaging techniques to better select patients. And then approximately, I'd say, mid to late pre the decade of the 2000, there was some interest in chasing the clot. And it took some time. The initial studies were mostly putting catheters into the carotid or the MCA, and then putting some IATPA, and most of those studies would not work very well. But certainly since 2013, so when Mr. Clean's results were announced, it's been an excellent journey out there, right? So let me just share some of that data with you. So to me, the big advances are first was that NENS trial, which put the treatment into a 3 hours time window, extended through the ECAS studies to 4.5 hours, and then more recently, about 3 years ago, with the Wake Up study, showing that in fact, if you properly select patients, you can treat them the next morning also. And then we and others have been doing some work with the stroke ambulance. So let me start there. So this was that seminal paper that was published in December of 1995, which used 4 outcome measures, looking at the NIHSS within the first 24 hours, and then at 90 days, the Bartel indexed modified Rankin scale and the Glasgow outcome scale. So it was a composite endpoint. But what's important, and since then has been used quite a lot, has been the modified Rankin scale. The modified Rankin scale in this study, and most thrombolysis studies, used a fairly aggressive 0 to 1, which basically, for those of you who don't do this, means a full recovery. So in patients treated under 3 hours, those who got the placebo, about 26% made a full recovery, and those who got TPA, this was 39. So the number needed 13% absolute difference, and number needed to treat is about 7. Remember, when you look at aspirin, the number needed to treat is roughly 100, and this difference is usually 1. So this is clearly a huge difference in there. Then after those ECAS trials, this was an important study which started looking at patients overnight. That's about 30% of the patients. Most of these patients were mild strokes. Their NIHSS was 6, and that's something one can debate with, in these 15 minutes or so. I can't go into too much detail. But the importance of this study, and the reason why I think it's important for us in many ways in understanding how we manage stroke, is that they used a technique. We don't use this in North America. We actually use a similar technique with CT, where we look at the core and we look at the mismatch. So if you have diffusion deficit, but no flare deficit, and here's a subcortical stroke, and big cortical diffusion, but no corresponding flare mismatch. So these are patients who probably had a stroke that's not of a prolonged duration, because the flare starts showing changes approximately in 6 to 8 hours. So mismatch would be up here. Then if you look at this one, so there's no mismatch. You can see that with the DWI, you've got flare. So this patient would not be enrolled to the study, and this patient would be enrolled. And they showed somewhat similar findings to what the NINS trial had shown, that you can see actually that about 11% of patients who got TPA, wake-up strokes, 11% more patients who got TPA compared to placebo did well. We use it quite a lot, but we use CT perfusion in these patients, and most of them tend to do very well. The more recent stuff is in the ambulance, and this is important because it gives you hope that if you treat early, you can actually see amazing recovery. So the NINS trial data showed that if you don't treat, so no treatment, 26% of patients would make a full recovery, and the rest would have some degree of disability. You treat them in the first 4.5 hours, this is the ECAS data, you go from 26% to 33%, which means now you got 6 additional patients who've done well. Then if you bring this down to 90 minutes, so this is in the first half of the NINS trial, this number increases from 26% to 48%. So that's pretty good, isn't it? But unfortunately, very few patients get treated within their first 90 minutes. The first hour, which is where I'm going to go next, is less than 2-3% of patients in hospitals. But if you have a stroke ambulance, as you can see in here, that number is over 60%. So it's clearly very, very impressive, isn't it? I just need to look into my slide here. So it's about 68%. So the earlier you treat, the better it is. And some of these technologies for example, the stroke ambulance is not available to most patients. Now, why are my slides not moving? So then, of course, came this era of stents, and my good friend Adnan, who's online right now, is one of the leaders in there. We've been using intra-arterial treatments for years. You put a catheter in, and unfortunately, it'll take a lot of time before that artery could open up. So in combination of good imaging and the ability to open that stent very quickly, and so allow for blood to move in, this changed everything. So just a comparison in here of the trials. The first one was Mr. Clean, and then several of these trials, we were very heavily involved in Alberta in Escape. And 2 things in here that I wanted to share with you is that if you look at the modified Rankin scale, it continued to improve over these studies. So you can look at Mr. Clean, for example, only 35% of patients made an excellent recovery. But in Extend IA or Swift Prime, these are more recent trials, you can see that 60 to 70% of patients were making better or full recoveries or nearly full recoveries. So this involved better imaging, which is really important, and it also involved better access tools. So in our study, if you look at the medical arm and compared it to the endovascular, then instead of 29% making excellent recovery, this went up to 53%. So clearly, the treatment is there. It is expensive, but it has excellent outcomes. The most recent ones were the 6 to 24 hours or up to 16 hours. So these are the so-called Dawn trial and the Diffuse 3 trials. And they've all shown that over time, your number needed to treat has been significantly improving. So my final slide in here shows you that this is a technique we use instead of the MRI. So you have the Rapid is one of the softwares. There are several softwares available. If the core is small and the penumbra is large, you go in and treat these patients aggressively. Here's what I wanted to share with you quickly from Qatar was the importance of registries. So if you look at this, over the years from 2014 to 2019, the number of stroke admissions, the total number of stroke admissions, had been, in fact, they doubled over this time. Then something very strange happened. In January and February, you can see these numbers are very high. In March, they suddenly go down, and they went down even further in April and last year. And so this is where the COVID cases started coming up. And so if you looked at these patients, because we knew what types of strokes these were, during this time, most of these patients that went down were in fact mimics and TIAs and mild strokes. Very interesting stuff. Led to several publications from Qatar. But if you hadn't had a registry, it would have been more difficult to trap these changes. But what's also interesting is that in the convalescent phase and also the second phase down there, that dip was not apparent. During this time, not only was the dip not apparent, several patients who'd had COVID and had recovered had had a stroke. So we compared them, and again, this is the beauty of a registry, that if you look at those patients who had recovered from COVID and then had a stroke, their modified Rankins of 0 to 2 was no different than those who had never had COVID. Whereas those who had COVID at 90 days, their modified Rankin scale was significantly lower than those post-COVID versus pre-COVID. So all of these things are possible if you have a good registry available to you. I spent some time looking at what's available in Pakistan. There's a lot of studies where institutions like Al Khan have participated in, for example, these are mostly data-driven studies looking at interstroke is a good example, or Interact is another good example. The cardiologists have put together this registry, and I was very impressed with this. As I speak with you, I'm on call also, so I'm going to wrap it up very quickly. So the cardiac registry in Pakistan is called CROP for short, is collecting data. And it's interesting because I spent some time looking for more recent publications. The most recent one I could see was 4 years ago, and this is in the public domain. So they were able to look at all the acute MI that had procedures done, and you can see it's a fairly large number in here. You can see it's almost 3,000 of these. They could look at what ages they were, what were the risk factors they had, and what were the comorbidities, and whether they were male or female. This is quite interesting, isn't it? 80% of them are actually men. This in itself is thought-provoking. But finally, as I end my presentation, I wanted to talk about what can you do in Pakistan. I think it's really, really important. It's similar to the cardiac registry, and doesn't take much. You can have it literally on an app. You can capture minimal data, the risk factors, types of presentations, how are you managing them, and what's the risk of recurrence, those kind of things. It's really important to have stroke units and have stroke designated hospitals where these patients could be treated early, and where you can offer them the kind of care that they need. As far as the treatments are concerned, I've spent a lot of time, spent more than 12, 13 years now, looking for possible sites that would consider Streptokinase and acute stroke. And the rationale is really very simple. As you can see, both TNK and TPA are important. They are somewhat expensive, and the uptake in Pakistan has been very dismal, and it's only been possible in a few hospitals. And I don't want to go into the details, but one needs to look at alternates. And similarly, endovascular treatment, which is highly effective, is also extremely expensive. And therefore, one needs to look at other options, especially where clearly there's no treatment available in these individuals. I've spent a lot of time in Pakistan making these presentations that those earlier Streptokinase trials were really flawed. They actually used a much higher dose fixed dose, and they were usually recruiting patients for 6 hours, but the majority of these patients, 80% of these patients were enrolled between hour 5 and hour 6. And I've looked at some of those imaging. The imaging was not very good. So the drug is considered dangerous because it causes hypotension and hemorrhage. And there's been this question that there's no benefit. In fact, if you look at those patients who were treated under 3 hours, and there's about 100 of those randomized, there was a clear signal of efficacy. So the problems have been in the past is the dose is too high, the window was too long, it was used in combination with aspirin and heparin, poor quality scans, and the measurement outcomes are not good. We have learned a lot now, and I think we need to go back and be a little brave. There is a lot of interest from outside. I mean, I know of at least a dozen neurologists who will come and help you design these studies. So in prevention, well, there's in acute stroke, well, there's so much that one can do, but there's major cost limitations. On the other hand, in prevention, I do believe that there's opportunity, and I wanted to share with you quickly 2 studies on the poly pill. I think the poly pill is the way to go. This is some work done in the US looking at individuals, low-income individuals, where there was a combination of antihypertensive and a statin used together. And you can see that if you have a single pill, the compliance is very, very good. And those who were given the standard of care, as opposed to the poly pill, did not do as well, and their blood pressure in general, you can see in here. So those who got the poly pill had a significant decrease in their blood pressure, 9 millimeters to be exact. And their LDL was also significantly lower than those who'd been prescribed these medications by themselves. And this is only 300 patients and made it to the New England Medical Journal 2 years ago. Earlier this year, this study is very, very important. This came out of Salim Yusuf's group. So they were actually looking at not only the benefits, but also outcomes. So they published it in January, high-risk patients with cardiovascular risk factors, and were given a poly pill that contained a statin, 2 antihypertensives, and they also used in one arm aspirin also. So clear decrease in blood pressure, clear improvement in cholesterol. And you can see that if you look at the actual heart events, there were about 19,000 patients in the study. The first heart event was significantly lower than those who got the poly pill. And if you include the poly pill with the aspirin, this group was even much better. So poly pill plus aspirin compared to double placebo, you can see the huge difference. Separation is early and they continue to separate. So this is the kind of research you can do in Pakistan. You've got to look at what is available and what is doable. And I certainly think that combination poly pill would be a very good thing to study in TIAs and patients who have had stroke to prevent recurrent disease. So I'm at my end, last slide. Stroke is a major problem. And around the world, I mean, I do believe there have been significant advances, and unfortunately, these haven't been translated into better care in low to middle income countries, and there are challenges out there. I think to be successful, there have to be local remedies for the problems in Pakistan, and I would really encourage most of you, because I've literally in the last 2 or 3 years, I've seen great deal of interest to have a group of individuals from Karachi to Peshawar and to Quetta and all through Punjab to see if they can have a trialist group that can start having meetings to develop local solutions to local problems. I will stop there as my 20 minutes are up. I thank you for your attention.
Well, Dr. Ashfaq,
yes.
I think for many years, we think that we have been struggling with this Streptokinase trial. The problem is probably the funding. There is some issues with the logistics. Maybe if we could get funding, I think this trial can be done in Pakistan, especially a pilot phase. I think 50 patients, with just a safety trial, basically see that if this medication is safe or not. So if we can do that trial, I think then that will become basis for a larger randomized trial. That's one thing. Number two, I think this concept of polypill is good for Pakistan because we have a lot of compliance issues and cost issues. I don't know how this works in US because it's a very different world, and it's in Pakistan the whole care is out of pocket. If we are able to come up with a cheaper option, like one tablet with the low cost and once a day maybe, including aspirin and plus antihypertensive and statin, and just patient has to take one tablet a day, I think that's going to be a very good option for the patient, especially if it's cost effective. But the question is that how can this be executed in Pakistan? I don't think we need a large trial, but a small study to show its implementability and executability in Pakistan. And then if we have industry who is willing to put something like that in Pakistan, then I think that will be a great service.
I couldn't agree more. Absolutely. This is the fun of being on call for the stroke service. I have to run. No, but I couldn't agree with you, Vasi. I think I couldn't agree more with you, I should say. We could talk. I mean, I think if you can set together a group of trialists in Pakistan who are serious and want to spend some time working on these two issues that you and I have discussed for quite a few years, we will work together, inshallah.